Wilson disease. This is a disorder of abnormally decreased copper excretion from the body. Because of the decrease in cerebrosplasmin, copper is not excreted and it builds up in the body in the liver, kidney, and red blood cells and nervous system. What most likely diagnosis? Okay. In addition to all the previously described periods of cirrhosis and hepatic insufficiency, you will answer Wilson disease as diagnosed FUC. Neurological symptoms: psychosis, tremor, dysarthria, ataxia or seizures. Coombs negative and hemolytic anemia. Coombs negative hemolytic anemia, tubular acidosis or nephrothesis. If Wilson disease gives psychosis and delusions, not the encephalopathic period or delirium that you would get with any form of liver failure. Diagnostic testing includes slit lamp examination, location of future ring, a brownish ring around the eye from copper deposition, best initial test. Urine test shows abnormal increased amount of copper excretion after giving penicillamine, most accurate test. Cerebroplasmin is usually low. Liver biopsy, most sensitive and specific, will detect abnormally increased hepatic copper. So set life, place of future ring, urine test shows increased copper excretion and cerebroplasmin low, liver biopsy, increased hepatic copper. Figure 1.12 copper deposit in the semicircular membrane giving a brownish ring around outer edge of cornea, Kaiser facial ring. Treatment in penicillamine, which will chelate copper and remove it from the body. Trientine is an alternative. Treatment is also used, which interferes with intestinal copper absorption. Decreased cerebroplasmin level is not the most accurate test. This is the most common wrong answer. All plasma proteins can be decreased with liver dysfunction and cirrhosis. Autoimmune hepatitis, look for young women with signs of liver inflammation with a positive ANCA. More specific tests are liver kidney microsomal antibodies, high gamma globulin, IgG, anti-smooth muscle antibodies, and anti-liver/kidney microsomal antibodies. The most accurate test is liver biopsy, treated with prednisone or azathioprine. Penicillamine cannot be used with allergy to penicillin, use zinc or trientine. Non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease (NAFLD) is a common condition in which there is excess fat in the liver of those who don't consume alcohol. There are two types. Non-alcoholic fatty liver (NAFL) is relatively benign and is not associated with fibrosis or malignant potential. Alcoholic steatohepatitis (NASH) is associated with inflammation and fibrosis and the potential to progress cirrhosis. NASH is potentially pre-malignant. The disorder is associated with obesity, diabetes, hyperlipidemia, and corticosteroid use. The most important diagnostic challenge is to exclude more serious liver disease. Liver function tests are often mildly abnormal. Perhaps the most accurate test shows the macrovesicular fatty deposits you would find in alcoholic liver disease, but without the issue of alcohol use. Treatment is correction of diabetes, obesity, and hyperlipidemia. There is no specific drug treatment to reverse any non-alcoholic fatty liver disease. Use vitamin E in everyone. Non-alcoholic steatohepatitis is treated with obeticholic acid. Obeticholic acid decreases progression, but it will not reverse severe fibrosis. If there is a non-alcoholic steatohepatitis and diabetes, the answer is pioglitazone. Model for end-stage liver disease MELD score. MELD score predicts survival in cirrhosis and alcoholic hepatitis. It uses age, creatinine, and need for dialysis, bilirubin, and NNR. Model for end-stage liver disease MELD score is critical in prioritizing who gets a donor liver first. High MELD means death sooner and therefore higher priority for getting liver transplantation. Benign liver lesions, focal nodal hyperplasia (FNH), rarely grows or bleeds and never becomes malignant. The key fact for you is imaging shows central stellate scarring, which is how you know it is benign. Focal nodal hyperplasia is from hyperplastic hepatocellular growth around an brown blood vessel. No treatment is needed. Hemangioma is the most asymptomatic, found incidentally with a small number of patients experiencing pericardial pain. Ultrasound, CT, and MRI eliminate the need for biopsy in most cases. Lesions less than 5 cm get no treatment. Unlike focal nodal hyperplasia, hepatic adenoma changes with hormone levels, and during pregnancy it may grow and even rupture. Adenomas can cause pain. Biopsy is the tentative diagnostic test. Because adenomas have a small risk of malignancy, biopsy is more essential in adenoma than in the other lesions. Focal node hyperplasia, central scarring on imaging, no malignant potential. Hemangioma, tough abnormal vessels, imaging diagnostic, no malignant potential. Hepatic adenoma goes with estrogen, large one may rupture, small malignant potential.